Thank you all for coming. This is my PGY-2 research proposal. My project's going to be the arterial anatomy of the deltoid ligament. Dr. Klein is my mentor. So some background to begin with. Ankle sprains are the most common presenting injury in the athletic population, and a couple of studies have shown that about 15% involve the medial side of the ankle with deltoid ligament. These are also commonly injured in ankle fractures. I think we're beginning to appreciate that more. Chronic deltoid insufficiency is associated with conditions such as posterior tibial tendon dysfunction, recurrent trauma, recurrent ankle sprains leading to deltoid attenuation and insufficiency. Dr. Gerber studied a cohort of military recruits that had ankle sprains and showed that those that had involvement in the medial side had much greater residual dysfunction at 6 months compared to recruits that only had lateral sided injuries. So these medial side injuries have been associated with more recurrent dysfunction, recurrent instability, and longer times to recovery. There are repair and reconstruction options available, either reconstruction with tendon allografts usually, or suture anchors for tendon to bone repair. And a study by Dr. Hinterman showed that 52 of these patients with chronic instability that underwent surgery for chronic instability, predominantly the lateral side of the ankle, also had medial-sided injuries as well that contributed to their instability. Folks that had reconstruction of the medial side had a 50-point increase, so from a score of 41 to 92 on their AO-FAS scores at 4.5 years. So that kind of illustrates that reconstructing or reestablishing the stability on the medial side of the ankle does significantly improve the outcomes in these patients. A little bit of anatomic background. So the deltoid ligament has been described anatomically a number of times, but it's generally divided into two components, the superficial and deep ligaments. The superficial component helps to resist external rotation of the talus compared to the tibia, and the deep component is thought to resist lateral translation of the talus in relation to the tibia. Both components resist valgus force through the ankle. There have been some previous studies from this institution. Dr. Gelman and the hand folks investigated the vascular supply to the flexor digitorum profundus insertion, and this provided some groundwork for information on tendon bone healing, and that's applicable in this case as a study by Krim, an MRI study of ankle injuries illustrated that the superficial ligament is most commonly injured as it avulses off the medial malleolus, and so reconstruction options involve tendon to bone repair. A second study out of this institution by Kathleen McCune a couple years ago illustrated the vascular supply to the syndesmotic ligaments, and this provided information about areas of hypovascularity that could potentially influence the chronicity or kind of severity, recurrent dysfunction or residual dysfunction of these injuries. So with that in mind, my specific aim is to provide a qualitative description of the intra and extraosseous arterial supply to the deltoid ligament of the ankle. My hypothesis is that the arterial supply of the deltoid ligament will be derived from branches of both the anterior and posterior tibial arteries and will exhibit a limited number of common vascular patterns that will be able to be identified. So for my methods, we'll be obtaining 60 cadaveric lower extremities. This will be 30 matched pairs. 20 of these will be frozen specimens, 10 will be unfrozen or fresh specimens. Specimens will be excluded for any evidence of lower extremity surgery or trauma. These specimens will be amputated below the knee, and the anterior tibial, posterior tibial, and perineal arteries will be cannulated and injected with India ink and Ward's blue latex. These will then be frozen for 42 or 48 hours. Afterwards, they'll be thawed. They'll undergo debridement initially, sharp debridement to remove the skin and subcutaneous tissues, and then debridement in 6% sodium hypochlorite to get down to the ligaments and bones. This leaves the casts of the arterial structures that the Ward's blue latex and India ink have formed. So all of those will have their extraosseous pattern of blood supply documented by photographs at serial stages of debridement. And then the 20 specimens that were the fresh or non-frozen limbs will undergo the modified Spaltholz technique, and this will allow us to visualize the interosseous arterial supply. The frozen samples cannot be processed for intraosseous examination because the freezing of the supply before injection disrupts the intraosseous vascular supply, so it's unable to be visualized with the India ink. So this technique has a number of steps. Basically, it's about a 4-week process that involves decalcification with formic acid and formaldehyde, and then serial dehydration with increasing concentrations of ethanol. And then the end result, you're able to take the osseous fragments, put them in methyl salicylate or oil of wintergreen, and that allows them to be translucent, and you're able to understand the vascular supply. Our plan is to take the distal tibia, use a Steinmann pin, and affix that to the talus so that anatomic relationship is still maintained, because this debridement will take away the ligament that's there. And so we'll fix those, undergo this technique to visualize interosseous supply, and then this again will be photographed and analyzed. So anticipated results, these are two clinical photos of one of our initial specimens, two of our initial specimens. So the deltoid ligament will receive its blood supply from the anterior and posterior tibial arteries, and like in the hypothesis, there won't be just one vascular pattern, but we anticipate that a limited number of common vascular patterns will become apparent. These pictures aren't the best, but this shows the posterior supply kind of coming in there on the posterior aspect of the deltoid, and then this is a pattern that we were seeing in the 4 specimens we did so far. It's kind of 3 arterial branches coming from the anterior tibial and its continuation in the dorsalis pedis artery, kind of tracking in anteriorly into the deltoid ligament. The limitations, so this is an observational cadaveric study, and you know,
why is that a limitation?
The fact that it's a cadaveric, well, I was going to say,
It's a prospective cadaveric study.
no, that's true. I mean, you cannot establish, causality between any of our observed vascular patterns and clinical conditions. And then, like Dr. Smith brought up, the identified vascular patterns can be affected by underlying patient conditions, such as peripheral arterial disease, diabetes, smoking, in addition to, cannulation or injection techniques can also affect the processing of the cadaver, can also affect the observed vascular patterns.